Cardiovascular disease is the #1 killer on the planet, and yet the most powerful diagnostic tool against it isn't an MRI machine or a troponin assay, it's a structured conversation and a careful pair of hands. Before any ECG, echocardiogram, or blood test is ordered, every great clinician walks through two foundational pillars: a focused cardiovascular history and a systematic head-to-toe examination. Get these two right, and you can often arrive at a working diagnosis before a single investigation comes back. The 2022 AHA, ACC, and HFSA heart failure guideline, along with the 2024 ACC and HFSA hypertrophic cardiomyopathy guideline, both make the same point explicitly. History and physical examination remain the cornerstone of cardiac assessment. No scan replaces what you learn at the bedside. In this video, we're building a complete diagnostic framework, from the questions you ask, to the signs you find on inspection, to the sounds you hear through the stethoscope, and finally, how all three combine into instantly recognizable clinical syndromes. This is high-yield material for USMLE, MRCP, PLAB, AMC, and MBBS candidates, and it's equally essential for any working clinician who wants to think like a cardiologist at the bedside. Let's build that framework, one layer at a time.
Think of cardiovascular diagnosis as a 4-step staircase. Step 1 is the cardiovascular history, the subjective narrative where the patient tells you, in their own words, about chest pain, breathlessness, or fainting spells. Step 2 is the cardinal signs, the objective data you gather through visual inspection and physical palpation, things like the jugular venous pressure, the character of the pulse, and peripheral stigmata on the hands and face. Step 3 is dynamic auscultation, actively altering the patient's hemodynamics with maneuvers like squatting or the Valsalva technique to unmask or confirm valve pathology through its acoustic signature. And step 4, the most powerful step, is syndrome synthesis, combining history, signs, and murmurs into definitive clinical equations that point unmistakably to a diagnosis. The core principle holding this entire framework together is simple. No imaging modality replaces the information obtained from a well-conducted clinical interview and examination. Master these 4 steps in sequence, and you'll find that conditions like aortic stenosis, mitral regurgitation, or cardiac tamponade stop being abstract textbook entities and start becoming patterns you can recognize within the first 2 minutes of meeting a patient.
Before you even examine the heart, the patient's background tells you where to look. Rheumatic fever in childhood remains the single most important cause of acquired mitral stenosis worldwide, a classic high-yield link for AMC and MRCP exams. Connective tissue disorders like Marfan syndrome and Ehlers-Danlos syndrome point you toward aortic root dilation and valve prolapse. Thyroid disease cuts both ways. Hyperthyroidism drives tachycardia and high-output heart failure, while hypothyroidism causes pericardial effusion and bradycardia. In cardio-oncology, anthracycline chemotherapy and HER2-targeted agents like trastuzumab are increasingly tested causes of drug-induced cardiomyopathy, and genetics matter enormously. Hypertrophic cardiomyopathy and familial hypercholesterolemia both demand cascade testing of first-degree relatives. On the pharmacology side, beta blockers, calcium channel blockers, and digoxin are classic bradycardia drivers. NSAIDs and COX-2 inhibitors can trigger heart failure decompensation. Tricyclics, macrolides, and antipsychotics prolong the QT interval, risking torsades de pointes. Cocaine and amphetamines cause vasospasm and hypertensive crisis. And on the guideline-positive side, SGLT2 inhibitors are now a cornerstone of heart failure therapy, proven to reduce mortality, while PCSK9 inhibitors like evolocumab are reshaping lipid management in high-risk patients. Newer evidence is now also expanding non-steroidal mineralocorticoid receptor antagonists and incretin-based therapies into heart failure with preserved ejection fraction, a fast-moving area worth watching.
Chest pain is the single most important cardiovascular symptom, and the Socrates mnemonic is how you dissect it systematically. Site is usually central or left-sided chest discomfort. Onset matters enormously. Sudden onset raises concern for aortic dissection, while gradual worsening over weeks points toward heart failure. Character distinguishes the differentials beautifully. crushing pain suggests acute coronary syndrome, tearing pain suggests dissection, and sharp pain suggests pericarditis. Radiation to the jaw or neck is highly specific for cardiac origin, while radiation to the ulnar arm is classic, and interscapular radiation screams aortic dissection. Associated symptoms like nausea and diaphoresis strongly suggest a myocardial infarction. Timing is diagnostic gold. Stable angina classically resolves within 2 to 5 minutes of rest. Exacerbating and relieving factors separate ischemic from non-ischemic pain. Relief with GTN supports ischemia, while relief on sitting forward suggests pericarditis. And severity is graded 0 to 10. For true ischemic angina, look for 3 features together: substernal pressure, exertional trigger, and relief with rest or nitrates. That's typical angina. Watch for Prinzmetal angina, a vasospastic variant occurring at rest, often in the early morning with ST elevation that responds to calcium channel blockers. And never forget the critical red flag. Women, the elderly, and diabetics frequently present atypically, with fatigue or nausea instead of classic chest pain, a presentation gap that costs lives if missed. Heart failure is best understood as a problem of fluid mechanics. When the left side of the heart fails, blood backs up into the lungs. That's backward left-sided congestion, producing exertional dyspnea, graded by the New York Heart Association, class 1 through 4, orthopnea, quantified by pillow count, and paroxysmal nocturnal dyspnea, a sudden awakening 1 to 3 hours into sleep that is highly specific for left ventricular failure. When the right side fails, blood backs up into the systemic venous system, backward right-sided congestion, producing an elevated jugular venous pressure, peripheral edema, and hepatomegaly. And when the heart simply can't pump enough blood forward, you get forward failure, fatigue, reduced exercise tolerance, and claudication, with an ankle brachial index below 0.9 confirming peripheral arterial disease. The 2022 guidelines make an essential clinical point here. Congestion itself, not just symptoms, is the primary target of diuretic therapy. There are also 2 rare but exam favorite positional variants worth knowing. Platypnea is dyspnea that's worse when upright, seen in hepatopulmonary syndrome or an atrial septal defect with positional right to left shunting. Tropopnea is dyspnea that's worse lying on one particular side, typically from a unilateral pleural effusion. Recognizing these fluid mechanic patterns turns a vague complaint of breathlessness into a precise anatomical diagnosis. When a patient describes palpitations, ask them to tap out the rhythm on the table. It's remarkably diagnostic. A rapid, regular tapping suggests SVT, atrial flutter, or ventricular tachycardia. A rapid, irregular tapping points to atrial fibrillation, and a forceful beat followed by a pause suggests ectopic beats. For syncope, use the discriminator matrix. Vasovagal syncope is preceded by a prodrome of nausea, diaphoresis, and pallor, that classic graying out sensation, triggered by prolonged standing, heat, or emotional pain, with rapid, brief recovery. Orthostatic hypotension is defined precisely: a fall in systolic blood pressure of 20 millimeters of mercury or more, or a diastolic fall of 10 or more within 3 minutes of standing, often triggered by dehydration or diabetic neuropathy. But cardiac syncope is the red flag category that must never be missed. Sudden onset, no prodrome, occurring at rest, or critically during exertion. Causes include complete heart block, ventricular tachycardia, hypertrophic obstructive cardiomyopathy, and severe aortic stenosis. Any syncope during exertion demands urgent echocardiography. Full stop, no exceptions. The European Society of Cardiology syncope guideline emphasizes that a detailed history alone can differentiate true syncope from seizures or hypoglycemia in roughly 60% of cases, making this one of the highest yield histories in all of medicine. A skilled clinician can gather an enormous amount of diagnostic information before ever reaching for a stethoscope, just by reading the body's peripheral signs. On the face and eyes, a malar flush, bilateral red, slightly cyanotic cheeks, is the classic look of mitral stenosis, caused by chronically low cardiac output. Corneal arcus and xanthelasma, yellow rings and plaques around the eyes, point to familial hypercholesterolemia. Central cyanosis, a blue tongue or mucosa, suggests a right-to-left shunt, as in Eisenmenger syndrome. General habitus matters too. A marfanoid build, long limbs, arachnodactyly, arm span exceeding height, flags aortic root dilation, while profound cachexia signals advanced, poorly prognostic heart failure. But it's the hands that tell the richest story. Clubbing, with loss of the normal nail angle, points to cyanotic congenital heart disease or infective endocarditis. Splinter hemorrhages, proximal nail bed bleeds, and the painful tender Osler's nodes are both classic infective endocarditis signs. Janeway lesions are the painless cousin. Flat, hemorrhagic macules on the palms, also from septic emboli. And tendon xanthomata, lipid deposits over the extensor tendons, are pathognomonic for familial hypercholesterolemia. Learn this map, and a 30-second hand and face exam can redirect your entire differential diagnosis. The character of the arterial pulse, best assessed at the carotid, is a direct readout of what's happening inside the heart valves. A slow-rising plateau pulse, a delayed, sustained upstroke, is the signature of aortic stenosis because the obstructed outflow tract slows the rate of pressure rise. A collapsing water hammer pulse, rapidly rising and just as rapidly falling, is classic for aortic regurgitation, and it's felt best by raising the patient's arm. A Bispherians pulse, with two distinct systolic peaks, suggests either combined aortic stenosis and regurgitation or hypertrophic obstructive cardiomyopathy. Pulsus paradoxus is an exaggerated fall in systolic pressure of more than 10 millimeters of mercury during inspiration, and it's the hallmark of cardiac tamponade. And pulsus alterans, alternating strong and weak beats in a regular rhythm, indicates severe left ventricular dysfunction. Blood pressure itself is equally diagnostic. An arm-to-arm difference greater than 20 millimeters of mercury raises immediate concern for aortic dissection. A widened pulse pressure above 60 millimeters points to aortic regurgitation, while a narrow pulse pressure under 30 millimeters suggests severe aortic stenosis or cardiogenic shock. 5 seconds on the pulse and the blood pressure cuff can tell you more than most people realize. The jugular venous pressure is arguably the single most underused and most informative sign in the entire cardiovascular exam. The normal waveform has 3 waves and 2 descents. The A wave reflects atrial contraction and actually precedes the carotid pulse. The C wave marks tricuspid valve closure. The V wave reflects venous filling against a closed tricuspid valve. The X descent is atrial relaxation, and the Y descent is the tricuspid valve opening for rapid ventricular filling. Now, the abnormal patterns are where the real diagnostic power lives. A giant A wave means the atrium is contracting against resistance, seen in tricuspid stenosis, pulmonary hypertension, and right ventricular hypertrophy. A Cannon A wave occurs when the atrium contracts against a closed valve entirely, a hallmark of complete heart block or ventricular tachycardia with atrioventricular dissociation. An absent A wave simply means there's no organized atrial contraction. That's atrial fibrillation. A large V wave, sometimes called a CV wave, is pulsatile and expansile, the signature of tricuspid regurgitation. And a prominent Y descent is Friedrich sign, classic for constrictive pericarditis. 2 bedside maneuvers complete the picture. Kussmaul sign, a paradoxical rise in JVP on inspiration, also points to constrictive pericarditis, while hepatojugular reflux, a sustained rise of 4 centimeters or more for 15 to 30 seconds of liver pressure, confirms right ventricular failure. Before you even place the stethoscope, palpation of the chest all gives you critical clues. A heaving apex, sustained, forceful, indicates pressure overload, as in aortic stenosis or hypertension. A thrusting apex, hyperdynamic but non-sustained, indicates volume overload, as in mitral or aortic regurgitation. A left parasternal heave signals right ventricular hypertrophy, and any palpable thrill confirms a loud murmur, grade 4 or higher on the Levine scale. Now, follow the acoustic timeline through one full cardiac cycle. S1 marks mitral and tricuspid valve closure, loud in mitral stenosis, soft in mitral regurgitation. Systole may contain ejection clicks, seen in aortic or pulmonary stenosis, or a mid-systolic click, characteristic of mitral valve prolapse. S2 marks aortic and pulmonary valve closure, and its splitting pattern is itself diagnostic. A fixed split points to an atrial septal defect, a wide split to right bundle branch block or pulmonary stenosis, and a paradoxical reversed split to aortic stenosis or left bundle branch block. Moving into diastole, an opening snap shortly after S2 indicates mitral stenosis, and the shorter that interval, the more severe the disease. Then come the gallop sounds. S3, an early diastolic sound from volume overload, has a cadence resembling Kentucky and is pathological in adults over 40. S4, a late diastolic sound from a stiff, hypertrophied ventricle, resembles Tennessee and is always pathological. This timeline is the backbone of cardiac auscultation.
Murmurs aren't static, and you can actively manipulate them to confirm a diagnosis by shifting the balance between preload, the venous return filling the heart, and afterload, the resistance the heart pumps against. Think of it as a seesaw. The Valsalva maneuver and sudden standing both decrease venous return, dropping preload. The acoustic result is striking. This maneuver increases the murmur of hypertrophic obstructive cardiomyopathy because less blood in the ventricle worsens the dynamic outflow obstruction, while it decreases almost every other murmur. Squatting does the exact opposite. It increases both venous return and vascular resistance, expanding the ventricular chamber and relieving the obstruction in hokum, so the murmur quiets down, while most other murmurs get louder. A passive leg raise mimics squatting by boosting preload, and it likewise decreases the hokum murmur. And respiration provides its own elegant physiological switch. Inspiration increases right heart filling, which amplifies right-sided murmurs like tricuspid regurgitation and pulmonary stenosis, known as Carvallo's sign, while expiration improves the transmission of left-sided murmurs like aortic regurgitation and mitral stenosis. Master this seesaw, and you can distinguish hokum from aortic stenosis, or confirm tricuspid versus mitral pathology, using nothing but your stethoscope and a few simple bedside instructions. Let's build the systolic murmur matrix pathology by pathology. Aortic stenosis produces a crescendo-decrescendo ejection systolic murmur, heard loudest in the aortic area, radiating to the carotids, paired with a slow-rising pulse, a soft A2, and a heaving apex. Mitral regurgitation produces a pansystolic or holosystolic murmur at the apex, radiating to the axilla, with a soft S1, an S3, and a displaced apex beat. Tricuspid regurgitation is a pansystolic murmur at the lower left sternal border with no radiation, but it gets louder on inspiration, and comes with a pulsatile liver and a giant V wave in the JVP. A ventricular septal defect produces a harsh pansystolic murmur at the left sternal border, classically with a palpable thrill. Hypertrophic obstructive cardiomyopathy gives an ejection systolic murmur at the left sternal border that, as we just covered, increases with Valsalva and standing, and comes with a double apical impulse. And pulmonary stenosis produces an ejection systolic murmur at the pulmonary area, radiating to the left shoulder, preceded by an ejection click, with a widely split S2 and a right ventricular heave. Notice the pattern. Location and radiation narrow your differential first, then the associated findings. The pulse, the apex beat, the JVP confirm the diagnosis with near certainty. This matrix, memorized cold, is worth enormous points on any clinical skills exam.
Now the diastolic and continuous murmurs. Aortic regurgitation produces a high-pitched, early diastolic decrescendo murmur at the left sternal border, heard best in expiration with the patient leaning forward, paired with a wide pulse pressure and an Austin Flint murmur at the apex. Aortic regurgitation also comes with an entire panel of eponymous peripheral signs worth knowing. Corrigan's pulse, a visible carotid pulsation,
De Musset's sign, head nodding with each heartbeat. Quincke's sign, visible capillary pulsation in the nail beds. Traub's sign, a pistol shot sound over the femoral artery. And de Rosier's sign, a to and fro murmur heard over the femoral artery with light compression. Mitral stenosis produces a mid-diastolic rumbling murmur at the apex, best heard with the bell in the left lateral position, following a loud S1 and an opening snap, often with a malar flush. If pulmonary hypertension develops secondary to mitral stenosis, listen for the Graham-Steele murmur, a high-pitched early diastolic murmur from pulmonary regurgitation. And finally, patent ductus arteriosus produces a continuous machine-like murmur at the left infraclavicular area, louder in systole with a collapsing pulse. Notice that diastolic murmurs are generally softer and require deliberate technique, the right position, the right part of the stethoscope, and patience to detect, which is exactly why they're so frequently tested and so frequently missed in real practice.
This is where everything comes together into instantly recognizable clinical equations. Acute coronary syndrome equals exertional or rest-crushing chest pain with diaphoresis, plus hypotension or hypertension with tachycardia, plus an S4 and possibly a new pansystolic murmur, signaling a mechanical complication like papillary muscle rupture. Acute heart failure decompensation equals exertional dyspnea, paroxysmal nocturnal dyspnea, and orthopnea, plus an elevated JVP and pitting edema, plus a displaced apex, an S3 gallop, and babasal crepitations. Severe aortic stenosis equals the SAD triad, syncope, angina, and dyspnea, plus a slow rising pulse and narrow pulse pressure, plus an ejection systolic murmur radiating to the carotids with a soft A2. And severe aortic regurgitation equals insidious exertional dyspnea, plus a collapsing pulse, wide pulse pressure, and that full panel of eponymous signs, plus an early diastolic murmur heard leaning forward. Notice that none of these syndromes rely on a single finding. Each is a convergence of history, a hemodynamic sign, and an auscultatory finding. That convergence is what transforms a list of isolated facts into confident, rapid clinical recognition. And it's exactly the kind of pattern-based thinking that examiners reward and that real patients benefit from.
Let's finish with 4 more high-yield equations. Mitral stenosis equals a history of rheumatic fever with hemoptysis, plus a malar flush and an irregular pulse from atrial fibrillation, plus a loud S1, an opening snap, and a mid-diastolic rumble. Infective endocarditis equals fever in a patient with valvular disease or intravenous drug use, plus clubbing, Osler's nodes, Janeway lesions, splinter hemorrhages, and Roth spots, plus a new or changing murmur, assessed formally using the Duke criteria. Cardiac tamponade equals dyspnea and chest fullness, often following trauma or malignancy, plus Beck's triad of hypotension, elevated JVP, and muffled heart sounds, plus pulsus paradoxus over 10 millimeters and an absent Y descent. And hypertrophic obstructive cardiomyopathy equals exertional syncope with a family history of sudden death, plus a jerky pulse and a double apical impulse, plus an ejection systolic murmur that paradoxically increases with Valsalva and standing. The 2024 ACC and HAA hypertrophic cardiomyopathy guideline specifically recommends cascade genetic testing for first-degree relatives once HOCM is suspected, a step that can be life-saving for an entire family. Across every one of these 15 segments, one truth holds. The stethoscope and the structured history remain the most powerful diagnostic instruments in cardiology, more than a century after their invention. Master the mechanism behind every sign, and the diagnosis follows logically every single time. If this breakdown helped clarify cardiovascular diagnostics for you, please like this video. Drop a comment with the syndrome you want covered next, share it with a classmate who's drowning in cardiology revision, and subscribe to Studious for more high-yield clinical breakdowns.